Good afternoon, everyone, and welcome to the Black Health Trust Weekly Program. My name is Michelle, and I'm your host here to introduce and to assist with today's program. Our discussion topic today is Intimate Partner Violence, an Evidence-Based Approach, Part 4, where we'll discuss domestic violence and the impact it has on our community. We're so encouraged that you've chosen to empower yourself today by joining us. As always, Black Health Trust is grateful to have its regular and faithful attendees back and those new to the program. So thank you again for being here. Knowledge is power and Black is beautiful. The panel will be moderated by the distinguished Dr. Randall Maxey, Chief Medical Officer of Advanced Community Medical Care Incorporation in Los Angeles and President of Black Health Trust. Dr. Maxey will introduce his distinguished co-moderators today and we will get the program going. Dr. Maxey.
Thank you very much, Michelle. I welcome my two distinguished co-moderators, Dr. Barbara Neighbor-Stevens and Dr. Ivan Waltz. And we're fortunate today to have Dr. Ron K. Bailey, past president of the National Medical Association and currently department chair and chief of psychiatry at LSU. And he's going to introduce our speakers in our panel, and Dr. Waltz and Dr. Neighbor, and I will ask hard questions as we go forward. Thank you so much. Dr. Bailey?
Dr. Bailey, can you hear us?
Yes. I missed it. Well, good afternoon. Yeah, Ron Bailey. Sorry for the delay there, technical glitch. As Randall Maxey, my good friend and fellow co-NMA past president mentions, I'm past NMA president 113, currently in New Orleans, been there for about a month or two in the role of chair of psychiatry, and I'm also assistant dean of diversity. So these issues regarding violence as a psychiatrist, and this more recent consideration regarding gun violence and partner violence are huge issues, I think, in my day-to-day life and work. We're happy that Randall Maxey's entire group, with Dr. Neighbor-Stevens and Dr. Waltz, have invited myself and my group to join and discuss a book that came out December of 2020, discussing this very topic. Very happy to have three co-panelists today. We have Dr. Muhayyed from UCLA Drew. Dr. Muhayyed is a young guy. He's a current resident. I'm very proud of him. We've worked together previously. We worked on a book on gun violence a few years back and wrote a chapter in this book on gun violence. And he's going to speak about some of the work that we've done together in that regard, and work that he's engaged in now there in Los Angeles as a second-year resident at UCLA Drew Psychiatry Residency. Next, we have Dr. Tiffany Bell. Very proud of her as well. Very happy to say we recruited her to join the Child Fellowship at Wake Forest. When I was chairman there, she stayed on as a junior faculty, did excellent work, was actually moving up to be the lead for the Child Fellowship. Now does some work, I think, on obesity as well. I want her to speak about a chapter she wrote in this book on teen dating violence, a topic we have not addressed yet up to this point. And third, also very excited to have a outstanding young doctor that I'm meeting recently myself as well, Dr. O. Berry. Dr. Berry actually has a grant in the state of New York addressing issues regarding intimate partner violence and work that they're doing there at Columbia University. And I'll speak forward. With that being said, thank you guys for joining, and let's go right to Dr. Muhayyed.
Excellent, thank you. Good afternoon. It's great to be here with you guys. I'm going to be sharing some topics like Dr. Bailey alluded to regarding intimate partner violence, or for others of us who are out there, domestic violence as it's known colloquially. And hopefully we're going to be able to kind of see how that merges today in this talk with firearm violence, and see the confluence of those two, and also in the sort of backdrop of how that might affect those in the Black community. All right, so a little bit about me before we start. I'm a second-year psychiatry resident at UCLA Drew, Department of Psychiatry. I have an interest in how violence and trauma might affect those in the sort of mental health realm. And I've worked with Dr. Bailey. I've been fortunate enough to work with several projects with him. Hopefully at the end of this presentation, I'll be able to talk about some of the things we've talked about, and I think the importance of having a bridge or a network between people who are established in the field of medicine, mental health, all those things, help those people get to those positions or mentorship programs. So we can go ahead and go to the next slide here. So just a background definition of what is intimate partner violence or domestic violence. Most people typically, when they think about domestic violence, the classical idea that comes to mind is definitely physical violence. Typically think of a person who's being abused as somebody who might have a black eye, be bruised black and blue, maybe broken bones, but there's certain things that also encompass domestic violence: intimidation, verbal threats, emotional abuse, sexual assault, and things like stalking. Stalking will be important maybe later on in this lecture, we'll see, usually is a harbinger to a lot of homicides that happen in relationships. And domestic violence can be by a current, former, date, spouse, or cohabitating partner. So again, something to keep in mind. Former partners definitely contribute to domestic violence and, importantly, to homicides. Typically, you see a peak after there's an attempt to separate in a relationship. We can go to the next slide. Considering our backdrop, being here with the Black Health Trust, we want to just kind of keep in mind that there's a higher reported incidence of domestic violence with African American women. We have here 43.7% of African American women reporting intimate partner violence, which can be rape, physical violence, stalking by a partner or former partner, compared to 34.6% of white women. Importantly, to keep in the context of this presentation and dealing with firearm violence and homicide, the mortality for intimate partner violence in African American women is nearly double that of white women. And then also we see some other things like that we've defined in domestic violence in terms of coercion and forced sex. There's like higher rates of HIV infections among African American women, also seen. We can go to the next slide here. So some stats to think about, just to put this into context. So if you have a female homicide victim, that is to say a person who was killed who's female, accounting all scopes of why that person ultimately died, 1/3 of those individuals were killed by a current or former intimate partner. And usually, again, it's at the end or during a separation of a relationship where there's a high risk for violence. Secondly, 2/3 of women who were killed by a firearm or a gun were killed by an intimate partner. And then lastly here, we don't want to neglect the fact that it's not just a female issue. There's also males indeed can be victims of domestic violence, but we see a skew here of 50% of female deaths in the context of domestic violence involved a firearm, compared to 43% of males. We can go to the next slide. One of the things that I wanted to talk about here in this next slide is that classically, as we look at sort of society and the thought process about what is domestic violence, traditionally, classically, it was thought of, it's a taboo subject, or it's something that is to be kind of left within the home for those partners or people in a relationship to kind of sort out themselves. And it wasn't really a thing that, you know, others wanted to interject themselves into or try to be involved in. And this also was the case for law enforcement people. And as we've moved as a society forward and kind of have recognized some of the warning signs of domestic violence and have come up with resources such as shelters, from our standpoint as like providers of care, screening tools and things like that, we've seen a somewhat of a decrease in domestic violence. And I'll talk about that in a second, a little bit later in this slide set. Has maybe some counterintuitive things. We can go to the next slide. So the first real legal protection that we have was 1994 Violence Against Women Act was the first law that was put forth that aimed at gender-related domestic violence issues. There was research funded, some legal protections. What I want to focus on here is the Federal Gun Control Act, which was passed as a part of this Violence Against Women Act, made it a federal crime to be in possession of a firearm while under a restraining order, and that's either protecting the partner or the child. And I think another thing that probably another presenter will talk about is definitely considering that, you know, having a backdrop of domestic violence certainly is an issue of child welfare. When you think about the conditions in which children live in, and as people have become more savvy to that, certain protections have grown to cover that. We can go to the next slide. And then specifically, there was a Lautenberg Amendment to this same Gun Control Act, which extends the prohibition of guns to non-felons if they're convicted of a misdemeanor crime of domestic violence. And I'm going to make a little aside here. In the scope of my practice, in terms of seeing patients as a resident, I've seen people from all swaths of life. But what I'm going to talk about, I guess, specifically here would be in like some of our veteran populations who typically are very well versed with firearms and also might, after they get done with the service, have jobs that require them to either be involved in security. And I guess you could also see this with like people involved in law enforcement. Unfortunately, if they have any kind of misdemeanor crime involving domestic violence, they're prohibited from gun ownership, and this can be quite problematic for them. And again, I think it addresses the larger issue of there is homicide, unfortunately. Not all relationships end cleanly in a less than ideal relationship, and sometimes tragically, those relationships can end in murder of one or both of those people involved. So definitely we need to be aware of that in terms of restricting gun access to people who are involved in a violent relationship. We can go to the next slide. There is some good news on the horizon here, is that there has been a decline in homicide rates and people in relationships that involve domestic violence. Some of the thoughts beyond proposed for this were there is a decline in marriage rates. This is not on my slide here. I'm going to try to quote the number, but I feel for like African Americans, I believe it's somewhere around 30% or so of adult African Americans are married, and I think the number is a little bit higher. This is not exact, maybe like 40 to 50% of the rest of America. There's a increasing age in first marriage. One would think there's maybe some degree of maturity that goes along with that, and maybe selecting a more stable partner. There's decreased economic dependence of women on men, although in terms of like people who are surveyed, and again, I didn't want to clutter the slide set. Financial instability is ranked as the #1 issue that's preventing people who are separating from an abusive partner. So as there gets to be more equity in terms of economic options, people are more likely to separate a relationship that's abusive and continue on with their life. Then lastly here, there's increased availability of services to victims of domestic violence, such as shelters, other resources. The stigma of it, although it's still there, is certainly less so than it's been classically. So I believe in like the past, we'll say 40 or so years from like the 80s until now, there's been about 50% or so decrease in homicides related to domestic violence. One interesting thing, though, that maybe is counterintuitive is that because of these protections that have been brought forth, what's happened is women have had more options to leave a less than ideal partner. So women are less likely to then wind up taking drastic measures to kill their partner. And thus you see a decrease also disproportionately in men who are killed by their female partners as opposed to men who kill their female partners. We can go to the next slide. Okay, so I think this takes me to the end of my presentation here. Just wanted to again reiterate that currently at a residency at Charles Drew as a psychiatrist. I'm enjoying my experience. A lot of this was predicated with some work that I did with Ron Bailey, who's on here today. I've had a pleasure of working with him on the topic of firearm violence and also domestic violence. We've put out some papers, and I'm definitely keen to talk about later on, if we have some time, the importance of having mentorship and people like Dr. Bailey to kind of guide us through our career as we go through the continuum of college and graduate education and further beyond that into residency and beyond, in order to get more people like us and who look like us into positions to help our community. So I think that's, for the most part, is our my part of my presentation here. So I think that I'm going to end. I believe my time is up. Thank you all.
Yeah, very good. So we're going to move next to, thank you very much, Dr. Muhayyed. Good job. I'll move next to Dr. Tiffany Bell from North Carolina.
Hello, everyone. While they're pulling up my slides, I just want to thank you all for allowing me to speak with you today. Thanks to Dr. Bailey for the introduction earlier. I will just briefly reintroduce myself as I was told to. I'm Tiffany Bell Washington. I'm a quadruple board certified adult, child, and adolescent psychiatrist. I also do obesity medicine and lifestyle medicine. I'm an incoming MPH candidate at the Harvard T.H. Chan School of Public Health. And there I hope to focus on health policies for minorities, obesity, and mental health. I have, just on a personal note, I have 4 children, ages 4 and under, including a set of twins and a 7-month-old. So I tend to be pretty busy, but when Dr. Bailey called and said he needed me to present, I was happy to do so. So I am speaking on teen dating violence. And I do want to say, because I have young children, I'm guessing one day in the far, far future, they will enter romantic relationships, and my hope is that I can warn them about the dangers of teen dating violence, and they can avoid that. So the slide set is up, but I cannot view my picture. Give me 1 second. Okay. All righty. So you will learn today about intimate partner violence and all of the effects that are very far-reaching from several of the other speakers. I just want to point out that intimate partner violence affects people from all races, ethnicities, genders, sexual orientations, social class, and also different ages. and it often occurs younger than we would expect it to. Early relationships set the stage for future relationships, and therefore we must take time to understand the impact of intimate partner violence on teen dating violence. Next slide. Okay. Intimate partner violence affects children in a number of ways, including difficulty coping with emotions and emulating these abusive behaviors that they see at home. This talk will focus on the downstream impact of the intimate partner violence that they may witness at home and their effects on the teen dating violence. Children exposed to intimate partner violence can develop numerous negative long-term effects. This increases their probability of them participating in teen dating violence and intimate partner violence as an adult in these later relationships. These children and adolescents often have difficulty coping with strong emotions, and they end up adopting similar abusive behaviors. And they may believe that violence is a normal way of resolving conflict and are often less likely to report this abuse or mistreatment. And as we said, more likely to perpetuate it. Next slide. Children and adolescents who have witnessed intimate partner violence are at increased risk for many things, and we'll kind of go down the list. So they have an increased risk of depression, substance use disorder, more violence in their adult relationships, anxiety, truancy from school, and that may happen for many reasons, but often if you're stressed, if you have low resources, if you're being abused, you're not going to focus very highly on school and doing well there. And we know that has far-reaching effects on our minorities and their ability to succeed if they're not completing high school. Withdrawal from school, dropping out, risky sexual behaviors and STDs, committing teen dating violence themselves, and difficulty in future relationships. And then all of these things could increase their risk of suicidal thoughts. And it used to be that Black children were at lower risk of suicidal behavior, but this has changed and it's actually increased for us. So we need to be sure that we are screening our youth for this possibility. Next slide. I'd like to share a few statistics about the prevalence of teen dating violence. It is more common than I initially thought before I began researching it. And 13% of males and 20% of females have been the aggressor in physical teen dating violence between the age of 13 and 16. So I found that very interesting because if you're looking at the numbers, 20% of females are actually
of the COVID-19 vaccine and vulnerable communities.
I'm not sure.
Is the ability.
Hopefully you can still hear me. Females are actually the aggressor more often than males, and that is not what I was expecting. But the study that I was reviewing showed that the girls are more likely to initiate violence in dating relationships. But we must keep in mind that the more severe forms of physical dating violence are perpetuated from males. The female victims were more likely to report being afraid or being injured by their partners, whereas the males were not. And we'll speak a little later about it. But when we're saying this violence, it's, it can be biting, kicking, scratching, slapping, pushing, shoving. So it isn't always just going to school with a black eye or being noticeable that they have been abused. The CDC reported in 2019 that 1 in 11 female and 1 in 14 male high school students experienced physical dating violence, as I mentioned before, and 1 in 8 and 1 in 26 male high school students reported experiencing sexual dating violence in 2019. Black youth are often recognized less often as victims of sexual abuse, intimate partner violence, teen dating violence, and then they also have the unfortunate situation of facing age and race-related barriers that prevent them from even seeking help. Okay, next slide. Our older adolescents who experience teen dating violence have a 2.5 to 4 times increased risk of smoking cigarettes, using illicit substances, and drinking alcohol than those who are not victims of dating violence. So hopefully you're beginning to notice a theme that they already had difficult home situations. Now they're in romantic relationships, which experimentation and dating are all normal parts of adolescence. And then they have trauma there, and they're continuing on this path of drug use, dropping out of school. And so it really is negatively affecting their life and their likely success later in life. 26% of women and 15% of men who are victims of sexual violence, physical violence, and or stalking by an intimate partner in their entire lifetime first experienced these forms of violence before the age of 18. So that's not, a lot of people are experiencing it as teenagers or children. Next slide, please.
Okay.
So this slide is a visual form of what we just discussed. The CDC has created a fact sheet that is easily available online and to be distributed to those who are interested, called Preventing Dating Violence. And we'll just quickly go over. So 1 in 11 female teens, 1 in 14 male teens have the physical dating violence. 1 in 8 female, 1 in 26 male have the sexual dating violence. And I just will stop here to note that for male young men, and probably older men too, they don't always want to disclose that they have been sexually violated, or they have this dating violence because they're wanting to be macho and they've been taught not to complain, and that these things might be normal, especially if they're seeing it at home. So you have to screen very carefully. 26% of women and 15% of men have had this violence before the age of 18, as we said before. Next slide. So we'll go over briefly just some treatment goals. When treating patients who may be experiencing teen dating violence, which could be any of your patients, it's important to consider the following: that we want to address teen dating violence early, before the negative coping habits are fully ingrained, because this can curtail the impact of intimate partner violence and stop the cycle of violence for future generations. So early is best, as early as you could think to ask. These patients are often filled with fear and distrust. They may not have come to the doctor willingly. Their parents may have noticed behavioral changes, or they're doing poorly in school, or there may not be parents who are noticing it because they have their own intimate partner violence to deal with. But this can also lead to less transparency and ineffective communication. It's important that we be non-judgmental and inquire about their experiences and their dating relationships. And you may even have to educate them what is teen dating violence, what is appropriate behavior in a dating relationship. They may not know that being hit, pushed, threatened, being forced to send nudes or inappropriate text messages or do sexual acts. They may not know that that is not something that happens in most relationships. So you have to be an educator there a bit. And you want to build a strong rapport and build trust early in this treatment relationship. And again, I just say screen as early as possible because children date earlier than we would like. They may not call it dating. Next slide. So according to the CDC, the following strategies can help prevent teen dating violence. And what you're going to want to do is give me one second. You want to teach safe and healthy relationship skills. So teach them what is a good relationship. You want to engage the influential adults and peers. Sometimes you can do Big Brother programs, or you can ensure that if a child and they don't have a healthy home situation, you can encourage them to go into some mentorship programs. You want to disrupt the developmental pathways towards partner violence. So if you can address the parents and teach, the mothers, for instance, encourage them to leave their situation if that is a possibility, or just some sort of positive reinforcement for good behaviors in relationships. You want to create barriers and protective environments, which means if the home environment is not positive, maybe they have an aunt or uncle or some positive adult to be with. Want to strengthen economic support for families. We know that being in poverty increases the likelihood of violence in the home, and that will, affect these children later in life. And then we want to support the survivors and really encourage them and strengthen their self-esteem. So I believe that is my last slide. Thank you very much for your attention, and we will go on to the next speaker.
Yes, and we're doing really good on time today. Barbara, if you'd like us to allow questions in the interim, we can. Or if you want us to all run right through it, we can do that. Take questions at the end.
We can go with a few questions now, Dr. Bailey, as long as I can ask the first one.
Well, I was going to ask the first one, but I think since it is your show, you have preference. But I'll just tell Wilbur I'm coming to him next,
Okay.
Dr. Wilbur Jordan. But you go ahead, Randall.
Okay. I have a question first for Dr. Bell. What is your advice to a father of a teenage lady or girl about dating and how to give me solace that she's well taken care of and not abused? How do I teach her? Tell me.
Well, I wish I had the answer for that. I think that being a good role model of appropriate behaviors for the father in his own romantic relationship is the best place to start, because children do what they see, not what they hear, often from parents. So demonstrating, what it is to respect a spouse or a significant other is always a good thing. And then keeping an open door for your young person to feel free to talk to you. And so if they're fearful that, if they tell dad, something happened, that he's going to flip out and lose control, and then they may end up getting injured even more, then they're less likely to do that. So keep a open door for communication. And then I would say starting as early as possible is saying maybe, when you start dating, make sure your person does this, make sure that they don't hit you, or if they do, just kind of warning them and opening up that line of communication. But yeah, if I find any tips, I'm going to use them myself. So
Thank you so much. Dr. Bailey.
And then there is a question in the chat room after Dr. Bailey asks his question. I'd like to identify that question in the chat box.
Right, I just want to kind of come to Wilbur. He's on regularly and speaks well, I think, on many of our topics. I don't know if you can see me, excuse me about this. And Dr. Jordan has worked in an area of what we call general internal medicine with a lot of psychiatric implications. So I was really caught by Tiffany's point that this idea regarding men being violated, and it made me think about Wilbur Jordan. I want to give him a chance to make some comments about that. And the particular question I'm asking Dr. Jordan, I see you on today, is what in your shop in HIV work over time, do you think of anything that you guys have implemented helpful? Because they were talking more recommendation and treatment.
Dr. Jordan, were you able to hear that? I know Dr.
No.
Bailey, you went in and out a little bit. Can you restate the question, please, Dr. Bailey? I think he may be having some technical issues.
Right, Dr. Bailey appears to be having some technical issues. Dr. Jordan, if you can hear us, I think Dr. Bailey was.
Can you hear me now?
Go ahead, Ron, if you're back.
I'll make it brief. I want Wilbur Jordan to address what, if anything, has been more helpful in his clinic with men who've been victimized in addressing these concerns, because very often in HIV clinic, we may be more likely to expect, we might see men who've been victimized sexually. In many settings, a man is reluctant to talk about it, but they're still trying to be macho and act like it wouldn't have happened to them.
And then Dr. Bailey, if you could change the landscape of your image, your sideways for us, just FYI.
Thank you.
Jordan.
64% of the men in OASIS give a history of being molested. 88% of their sisters give the same history. And the first thing we had to do is really identify the therapists who were comfortable talking to men about being raped and molested. All of them were not. Michelle Clark was my first, who was. And that became very important, to have someone who could sit there and really talk. You can't do that in 15 minutes. That's really an hour and a half discussion, because these are grown men now coming in, and they're starting off with things that's happened to them over and over for 10, 15, 20, 30 years. And so you need to do that. It's a hell of a big problem. I think one of the biggest problems, I'm glad Ron asked about it, because I think we keep omitting it. And when I am 9 years old and my mama's boyfriend sneaks in my bedroom, puts his private parts in my behind or my mouth, I am sitting here now 45 years old and it's still effing my mind up. And we don't realize that. And whether I'm a girl or boy, it doesn't matter. And I've had patients, I've had 3, in fact, come and tell me how to do it. They've gotten so good. In fact, I have one, he won't date you unless you have a 12-year-old daughter. So, I mean, it's a hell of a big problem. And I think we need to address it more. So thank you for asking me about that. But every patient we see, we address that issue. And like I said, 64% of our men will give a history after we talk to them. They don't come in and say it, but we have to sort of let them know after about the 3rd visit, they'll bring it up.
Thank you, Dr. Jordan. That is very heavy and very important. Am I okay with addressing Reverend Pointer's question in the chat room now, or do we need to move forward?
Go ahead.
No, go ahead. We're doing good on time today.
Okay, I believe this came in while Dr. Bell was speaking, so I think it's in the context of her research. Forgive me if I'm incorrect about that, but the question is, are we to include in those identified as IPV victimized, those who have been emotionally involved while not cohabitating previously? For Dr. Bell?
Okay, I am.
Oh,
Yeah.
okay.
Yes, so I absolutely would include emotional abuse in teen dating violence specifically, but in intimate partner violence in general as well. I think that most abuse doesn't start with being hit. You know, it usually is that you're slowly disrespected or maybe talked down to, or they're isolating these children and teens and adolescents, and making it so that they don't go to their support system right away, you know, if they do have someone to talk to. So I would not neglect the emotional abuse, and I would open up the door to discuss that early and often, so you can catch it and hopefully prevent it from escalating to the physical abuse. And if someone else has something to add, that'd be fine as well.
I would also be talking about the more general constellation of abuse within my talk as well. That includes emotional abuse, physical abuse, as well as financial and stalking. So we'll see more of that picture in my talk shortly.
Terrific.
So can I just jump in? I really wanted to underscore something that Dr. Jordan said, which was about identifying resources when you do screen and you get someone that has that history. So often we open a box that we don't have time to get into, or we don't have resources to deal with. And so I just really enjoyed hearing Dr. Jordan say, one of the first things we had to do was identify the people that could really do this, because when you begin to screen, when you begin to ask the questions, I know so many times that folks will say, well, let me tell you. And when they tell you, you really have to be able to take care of that in a way that is meaningful, because it makes it harder then for them to tell somebody else if you kind of mess that up. So
I would like to go back to something that she said as well. It was really the question that Randall asked, because I was going to ask it and I want to push it. You know, we are talking to an audience of parents and grandparents and aunts and uncles. What we really want to make sure we give is information that they can use in their own situations. And yes, starting with the parents and their interaction with their children in their overall process of upbringing, self-respect, and the issue of self-worth and how other people can manipulate you through using your self-image and your self-worth to achieve the goals or the aims that they wish to achieve. I hope that we can have a little bit of conversation about that, because the people who have the first opportunity to impress the importance of that on their children are the parents. And then the rest of the village that encompasses the children. So I'd like to throw that back out to Dr. Bell and anyone else who wants to comment on it, because as a pediatrician, I can tell you from firsthand experience that you have a tremendous amount of impact on young people and young minds in just very casual conversations. And so we have plenty of opportunities, I think, to help arm our young people so that they are able to deal with these situations when they are confronted with it. Now, I know we have been talking about the context of coming out of a home where IPV is present, but every child needs to be raised and counseled on how to deal with some of these life situations that they are going to have to deal with. And today we're talking about dating abuse, but the same comments obviously can be made on others. So I'm going to throw it back to you, Dr. Bell, and then invite others to comment on that.
Thank you. Thank you very much for that. I was trying to keep my answer brief because I wasn't sure how much time we had, but you're absolutely correct. It is something that every child has the potential to be abused or to be in a relationship that is becoming violent. And I will say that I actually think you should start very young. There are books, I read them to my children, but there are books on consent, body consent, learning to say no if you don't want someone to touch you, even in what they perceive friendly way. They want to give you a hug, you don't want to hug, and to teach them about body autonomy, essentially. But I also have a resource that I do give to teenagers, and I give to parents, and it's a hotline and also a online. They have a website as well. So I don't know if you all have pens. I can type it in the chat box as well, but it's called loveisrespect.org. And that is a national teen dating abuse helpline, 24 hours a day. It's created to help generally teens 13 to 18, but younger ones can call if they need to. And so parents, teens can call, and they can give you more resources and confidential assistance. So I agree with the doctor who said, you don't want to open up these wounds and then don't have a way to deal with the truth that comes out after you ask these questions. So I would tell parents to look at that if they're on this webinar as well. And the CDC does have a lot of resources and actual data sheets to kind of give more information about this as well. But it does start at home, and it does start with teaching self-worth and trying to teach our youth, especially our vulnerable minority children, that, you are worthy. You don't have to do these things. Some people think they may have to be in bad relationships for financial reasons to help because they don't have the money or the things that they need. And so we do have to start early. And maybe someone else has something to add.
Yeah, I do want to add to that. Thank you so much, Dr. Bell, and thank you so much for the question. So as a child psychiatrist and women's mental health psychiatrist myself, one of the things, and also public health degree, one of the things is about prevention. And as Dr. Bell iterated, you need to start early. You need to start young. You need to start before the child is even born for those parents to have a better understanding of what their relationship is between their parents. So you can think about intergenerational transmission of trauma. Think about what the parents have about their parents, how they were parented, and how the environment they want to create for their child. And by doing that early on, especially within the first 5 years of life, where we know that the brain is maturing very rapidly, and one of the best hallmarks for showing brain development is actually stability and safety and attachment during those years. And having a stable home where they're not worried about the safety of their parent, but they're also not worried about their safety themselves, really kind of fosters that and carries it through the next generations up to the teen years and into adulthood. So it really does start early on. And part of the preventing process before even getting to the child dealing with what they need to do in their trauma is really how do you embody and empower the parent both the woman and the man, to be able to provide the stability that they need for their child to succeed. If that means thinking about trauma and how it affects their lives, thinking about the mental health impact in terms of depression, anxiety, PTSD, all that needs to be addressed. And there's plenty of research that shows that if the parent is well treated and they are very well treated in terms of their mental health, that's going to be proven to be very, very helpful for the child's emotional well-being moving forward in life.
Can I say something, please?
Yes.
Because we keep talking about parents with an S. And most of these kids have a parent, not parents. And that's one of the damn big problems. And we're not helping them at all. And their mamas are dating guys who ain't working, laying at home all day and abusing the kids. I have patients who give me lessons on how they can rape their girlfriend's kids and still have her coming back. I mean, it's one thing if we're talking about middle class folks. It's something else when we're talking about really the working class. And too many of our kids now are in environments that is awful. I thank God every night from my childhood. I had a wonderful mother and father, a hell of a good daddy, and most of these kids don't. In fact, when we first started the AIDS clinic, we had men's group. I couldn't talk to the men because I tried talking about my father, and they started looking at me as if I was crazy.
Didn't have one, right?
No, they raised their hands and said, you really had a father? And I'm saying, yeah. I mean, they didn't believe me. And you realize there's a whole subset of kids. They don't know. I've been asked 32 times by my patients if I could be their father. They have no idea who their fathers are. It isn't Mr. Jones across the street anymore. I mean, so we have to realize some of these kids are in awful situations.
Yeah.
I mean,
and that's the leading part. Well, I think to what Dr. Beer is going to speak about it today.
Yeah, and I think I'm going to address that. And
I saw
before I
it
get
in
to
the
my
chat about incest as well. We'll come to that. So we go to Dr.
I just
Beer.
want to, can I just address Dr. Jordan's point before I get to my talk? I agree with you. The idea of what is a stable family unit is very, very different. You know, it's different for everyone. It doesn't always have to be the biological mother and the biological father. What research has shown is that having a stable caregiver, whether or not it's a biological caregiver, is very, very important. And it could be a mom, it could be an aunt, it could be a grandma, it could be a grandpa, it could be a cousin. But having an adult person in your life is also very stable. It could be a therapist for that matter. It could be big boys, big girls, whatever it is. That's also very stable for the child. That's also very stable for the caregiver to have that other supportive network that they can actually rely on to call for help. Hey, I can't pick up my child right now because I have to work this extra shift. Can you come and help me? Having that other extra support is very, very stable for all families involved. And that's all I want to say is that it really is protecting the caregiver really helps protect the child too, and vice versa.
Thank you.
Excellent.
Dr. Beer, are you up?
Great.
Glad
Let
to
me
have
share
you.
my screen. Great. Well, thank you so much for having me, everyone. This is such an important talk and really kind of exemplifies a lot of the work that I continue to do and have been doing for over the past almost 15 years now. So just to give you a little bit of background about myself, I'm a child psychiatrist, adult psychiatrist, and a women's mental health psychiatrist, and do some research on the side as well, mostly around the areas of family trauma and intimate partner violence. Currently, I actually was at Columbia, but now have moved to NYU, where I am the medical director for New York City's Health and Hospitals, which is actually the nation's largest public city hospital in the country, and for their domestic and gender-based violence mental health collaboration. And in that role, what I do is oversee the department's, the public city's hospital response to gender-based violence and domestic violence by improving its capacity to take care, as well as also doing an integrated program within a non-medical setting. And then I also have a practice at NYU where I see children and women thinking about, again, that intergenerational transmission, think about perinatal depression and trauma and how it ultimately impacts kids in early childhood mental health. So my talk is going to be about caring for women and families affected by domestic violence, integration policy and practice. I have a lot of slides. I'm going to try and get through them, but I think Dr. Bell and Dr. Muhammad did a great job to set me up for this talk, and a lot of the discussion we've had so far has been really profound. And I think anytime I come to these panels and talks, I'm always like, there's so much more that we can do, so much more we can think about. So happy to be here. So I'll first start off with a definition just to make sure that people know what we're talking about. Oftentimes we use these terms, intimate partner violence, domestic violence, and family violence very interchangeably, but they do mean different things. So when we think about domestic violence, we think about it as all encompassing about family violence and intimate partner violence, and specifically really talking about the domestic household, what happens in that specific household itself, where people are related by blood. So oftentimes child abuse and incest will fall under that, or even sexual trauma within the home will fall under that. Elder abuse would also fall under that category as well. Whereas intimate partner violence is really around romantic partners, whether or not they're married, whether or not they live in the home, whether or not they're currently together. It could even be a previous relationship too. It does not necessarily have to be that they have to be in a household unit. It just means that they had some type in their life, had an intimate relationship. Regardless, all of these terms, what they really want to convey is that it is a range of coercive and abusive behaviors used to maintain power and control over another person in that relationship. That is the overarching definition of what we think about when we think about intimate partner violence or domestic violence or family violence. In terms of forms of IPV, again, I think this is where we could really do a good job of just educating ourselves about what this means. And as Dr. Bell had pointed out, sometimes it's not even physical violence is the first thing that happens. It's usually like this slow kind of buildup of intimidation or threats or emotional abuse before the physical violence takes place. But that should always be a clue to you that something's off, like a red flag that something's off. So there's physical violence, which most people know about, the grabbing, the pulling, the stroking, the punching, the kicking, the strangulation, the choking. Then there's emotional abuse, such as gaslighting, telling somebody that they turned off the lights when they didn't turn off the lights, the isolation from family members, the verbal, even using religion as a way to emotionally abuse somebody, using children, saying that this person, I'm gonna take your children away if you don't do this for me. There's financial abuse, which was really a big issue within COVID when people couldn't leave. And as Dr. Mahat pointed out, one of the biggest barriers for people leaving an abusive relationship is not having financial access to leave. And so sometimes in these relationships, the coercive abuse is really about restricting or removing assets, holding some money so that they don't get it. Even if that person is a primary caregiver, primary breadwinner, that the money is being restricted from them. And there's also sexual abuse that also comes into play too, including reproductive coercion in many different ways, that the partner will force somebody to have a child or force somebody to have an abortion, intentional transmission of STIs for that matter, sex trafficking, being coerced into sexual acts or rape. And of course, you can still be raped even if you're married. Again, thinking about the definition of marriage still, and sexual abuse still includes people being raped within the household and within the marriage unit. And of course, using intimidation or threats, such as using a system, which is very much the case for our Black and Brown families, saying like, if you don't do this, I'm gonna call the police on you. Or for people who are immigrating, if you don't do this, I have access to giving you your green card, and I'm not going to give you that unless you do so and so and whatnot, or even stalking violence. So these are the various forms of IPV, and they're still continuing evolving for that matter. One of the things that I've been seeing in some of my practice that falls along the lines of financial and stalking is the use of technology. So being able to follow somebody on Instagram and see exactly where they are based on the pictures that they used. Or most recently, somebody told me that their partner was stalking them based on their Venmo account. And if you guys know the app Venmo, if you have a public view, they can see what actions or what money you use to spend on an event. And a partner can actually stalk you using those forms of technology. In terms of epidemiology, we kind of talked about this too, that, it's fairly common. The one thing I want you to take away, it's fairly common for both men and women for that matter, that more than 1 in 3 women and more than 1 in 4 men, and this is the United States, have experienced rape, physical violence, and are stalking by an intimate partner in their lifetime. For people who are of LGBTQ variety, that their experience IPV may be at rates higher or equal to than non-LGBTQ individuals. And part of it has to do with also ultimate forms of different IPV that exist. In addition, people of color who are undocumented, people living with HIV, or people with disabilities may experience IPV in different ways and unique challenges and barriers to resources. So for example, within the LGBTQ community, one of the risk factors for IPV is actually the fear of being outed to family or society by your partner. They can use that as a threat. Or for, within the Black community, again, the fear of not wanting to call the police because you fear that the safety of your partner who's abusing you more than what's happening in the home. Again, just to reiterate, so I live in New York City. This is data from 2020. So during the midst of COVID, there are about 16,458 reported domestic violence reports that were responded to by the New York Police Department, which averaged around 45 a day. Again, in 2020, during COVID, in the city of New York, which is a large city, but that's 45 reports being admitted, being called to New York Police Department daily. And if you can imagine, that's probably an undercount of what actually truly occurs. Putting on my women's mental health hat, how does this impact women? And so I mentioned earlier that there's this notion that 1 in 3 women and 1 in 4 men have been a history of IPV, but we oftentimes think of IPV as gender-based violence. And part of it has to do with that there are discrepancies in terms of the severity, the frequency, type, and lifetime impact of IPV. This is something that Dr. Mahad also alluded to, where that on average, women are more likely to be killed, die by homicide by intimate partner than men are, and they're more likely to be raped than men are, and they're more likely to have much more severe and frequent reports of intimate partner violence over their lifetime compared to men. One of the other things that's really interesting that's coming out in terms of our research and literature has to do with the connection between intimate partner violence and terrorists or mass killings. This is a report that came out in 2020 from the Brookings Institute. They analyzed about 750 mass shootings, which they defined as over 4 people being killed between the periods of 2014 to 2019. And they found that 60% of those people who actually committed those mass shootings had a history of intimate partner violence. And the deadlier the shootings, the more people who died, the more likely they were to have a history of intimate partner violence. So it was a one-to-one relationship that grew exponentially. On the reverse, if a woman was a gunman, which is much less common when you think about the epidemiology, she was had a history of being a victim. In terms of pregnancy, for a while, people actually thought pregnancy and being pregnant was a time of actually reduced risk because it was supposed to be a happy time and a joyous time. But what we actually realized that it was actually a time of increased risk. And oftentimes it just has to do with the constellation of what's happening, the added stress that goes on with being pregnant and not knowing what's happening. Even though it's a time of increased risk, it's also a great time to reach women who are at risk and not only just screen, as we talked about, but providing them with resources if they're in trouble. Because of this, ACOG, the American Academy of Obstetrics and Gynecology, recommends screening during your first prenatal visit, first trimester, postpartum checkup. And the reason it's a great time to reach women at risk is that when women are pregnant, they're much more likely to make changes to their life. Not only because they're not only thinking about themselves, but they're thinking about the future of their baby. So again, it's a great time to intervene. In terms of Black women actually prefer talking to a reproductive health provider, twice as much more likely than white women. So again, another opportunity to reach those Black women who could be making changes to their lives. The risk factors, why it's important. Why do we think about pregnancy and intimate partner violence? Because it comes with a lot of complications, poor health outcomes for mom and child, delays in prenatal care, low birth weight, premature birth, uterine rupture, even loss of the baby. perinatal homicide and suicide, attachment difficulties, which is something I alluded to, again, being able to form that bond with the child, as well as postpartum depression. And a paper that came out several years ago, but I still think is pretty profound, is, people often talk about maternal mortality. And when they think about it, they think about the physical and the medical complications such as preeclampsia or placenta previa or hemorrhage. But actually, when you look at this data and this figure, on the left-hand side is pregnancy-associated homicide, followed by pregnancy-associated suicide. Pregnancy-associated homicide and pregnancy-associated suicide had higher rates of mortality compared to placenta previa, eclampsia, amniotic fluid embolism. So higher rates of those medical concerns was due to homicide and suicide. And when they actually dug in deeper to that data, what they found was that around 53% of women who died by homicide had a history of intimate partner violence. About 40% of women who had a history of pregnancy-associated suicide had a history of intimate partner violence. So it's there, it's real, and it's something we need to take seriously. In terms of impact on physical health, we know people talk about the physical health impact, the brain, the nerves, the stomach, and pancreas, but really there's this combination between psychological health and physical health. You can't have true health unless your mind is right. And we know this is because when stress and trauma are often associated with poor health outcomes. If you have a history of stress, history of toxic stress for that matter, you're much more likely to have higher rates of morbidity and mortality, much more likely to become obese, much more likely to die by hypertension or any type of cardiovascular risks. In terms of mental health effects of IPV, this is something I often do in my work, is what are we concerned about? What are those diagnosable DSM-5 diagnoses that we are worried about? People think about PTSD. Of course, there's a trauma and there's an event and there could be a post-traumatic stress disorder. But there are also other types of mental health disorders that are associated with intimate partner violence, depression, and as I alluded to, postpartum depression, anxiety disorder, substance use disorder, suicide, sleep disorders, poor perceived mental health, and comorbidity. And what I mean by this is that instead of just being diagnosed with one disorder, what we're seeing within our patient population is that they're often diagnosed with 2, 3, or 4 DSM-5 diagnoses. So there's a lot of overlap in terms of how they're being diagnosed because it's really damaging to the psyche and the safety and can have long-term outcomes, mental health outcomes. In addition, mental health and intimate partner violence is bidirectional, meaning that IPV increases the risk of mental illness, which themselves increase the vulnerability to IPV. How will this present? What will you see when you are encountering somebody in your clinic or even encountering somebody just on the street or a friend? People say they have headaches, they feel fatigued, low motivation, feeling heavy, they're not sleeping, they're tearful crying, low self-esteem, not wanting to be alive, anxious, zoning out, feeling paranoid that somebody's out to harm them, not being able to function, or just having a whole range of somatic complaints, body complaints, such as chronic pain, choking sensations, hyperventilation, or even just stress-related symptoms by having repeat healthcare visits, or even delaying seeking care. And even though people may not meet DSM-5 diagnosis, trauma survivors will still exhibit some constellation of these symptoms. In terms of IPV in children and adolescents, again, this is some part of my research I do, is that we can't always think about the adult in the picture. We also really need to think about the child who may be witnessing or who actually may be a victim themselves. Children who witness IPV can get harmed by both ways, both indirect and direct. And what I mean by direct is that 1/3 of children who witness IPV are actually abused themselves. So 33% of them who are in the household where there's intimate partner violence taking place between adults are actually abused themselves, either physically or sexually, emotionally, or even through neglect. It can also have indirect effects, which means that the influence of the caretaker, the parent's ability to actually provide that safety for the child is being compromised, either through parenting, not being able to be the proper parent, such as being too permissive or actually being too harsh. And oftentimes these effects can be seen as early as even 6 months old, where we've seen some cases where babies are just no longer attached to the parent, and then can extend throughout adolescence. And as Dr. Bell alluded to, can really affect their own understanding and identity of how they want to be a partner in romantically. But most of what we see is social emotional functioning, so much more aggressive outbursts, or even internalizing, so much more anxious. They may complain of physical complaints, having to complain about stomach aches or headaches, or even just feeling they're not sleeping as much. We have seen some reports in terms of research with some cognitive declines and not being able, and I think this has to do with just how parenting is affected, not so much the direction of IPB, but just how it affects parenting. And then some of you guys may have heard of the ACEs study, the Adverse Childhood Experiences, which is a composite of about 10 different categories where children can be ranked to see if they are at higher risk of having these experiences. Having a history of DV at home, being abused sexually or physically is also a criteria in that. And so what can we do about this? We've talked about all of these facts and it's terrible and it's sad and it compromises not only individual families, but society at large. So what can we do about this? And so in New York City, we've actually put together a call to action. How can we really think about the interplay between mental health and domestic violence and be able to not only screen, but provide resources for families in need? And through this initiative, we have partnered through Health and Hospitals. Hospital system has partnered with the New York City Family Justice Centers. Family Justice Centers, there's actually one in every single state in the country and some internationally. It's been identified by the Department of Justice as the best practice for intervention and prevention of intimate partner violence. It's a one-stop shop for survivors and families to come in to get all types of resources. So they have access to legal services, access to housing, access to economic empowerment, access to childcare. And for the first time in the country, we have access to mental health services via a psychiatrist or psychologist. In terms of just how much people we see, in 2020 alone, so there's 5 FJCs in New York City, which is the largest FJC conglomeration in the city. We were seeing about all of FJCs were seeing about 119 clients daily, despite, again, the lockdown methods that happened in New York City when we were hit very hard. We were still seeing 119 clients who were coming in trying to get the help that they needed. Again, here's a list of all the FJCs that we that they offer, and again, there's an FJC in every state. So look into that because it is a powerful resource for families. It's walk-in and it's free. And so in New York City, again, we're offering individual counseling, group counseling for both adults and children, and we also provide psychiatric services. We started in 2017 and we are in every single bureau in the city. Our services, as mentioned, we have a psychiatrist, a therapist, administrator. All our services are free, no billing. We do a lot of evaluations, so really thinking thoroughly about how much does trauma impact this child's life as well as this parent's life. And really not just being prescriptive by saying, oh my gosh, the child has ADHD, but really thinking, could it be trauma that's affecting their child to be able to regulate their emotions? We provide acute crisis treatment, so really thinking about how we acutely stabilize the parent and the child, either through medication management or through therapy, which is individual or group-based. And then on top of that, we do a lot of trainings to staff who are non-mental health clinicians, just on understanding the interplay between mental health and intimate partner violence to reduce the level of stigma that can be seen when people try to access services. Since the start of our program, we've seen about 1,500 unique clients. Our populations, it's New York City. So 60% are parents, with 30% of them having children under the ages of 5. And again, one of the reasons I think it happens is that, again, between parents, and usually women, are much more likely to make changes to their lives because of their children. So if they have a child, they're much more likely to try to get help. But 27% are African American, 64% are Latinx, 9% are white, 92% live under the federal poverty line, 73% are housing insecure. Majority of people do not speak English. 30% speak a primary language other than English. And despite this, we're able to get the help that we to these families through trauma-informed care that's culturally and linguistically relevant to their needs. We've noticed about 3 months of treatment that we've been able to improve depressive symptoms, anxiety symptoms, and PTSD symptoms. Clients and staff have also noticed that their quality of life has improved, that their mood, sleep, distress, suicide ideation, and relationship with family and children, and relationship with the actual organization has improved as well. This is a woman who I just recently saw, but I really just want to get you an understanding of what was going on with her. For sake of this, I'm going to call her Patricia. She was actually a first-time mom who was in her second trimester, had a history of childhood abuse, had witnessed intimate partner violence, had been physically abused by her parents, and then was in a relationship and everything was going smooth. And then in the midst of COVID, he had hit her during her second trimester. She was fortunately was able to get connected to the Family and Justice Center, file the restraining order because there was a legal services there on site for her. And then she was connected with a housing specialist because she didn't have a place to go. And so she was fortunately able to get put into a shelter system, got connected to a psychiatrist who put her on SSRI, who's also doing individual therapy. And although there were dips in her mood, because not everything was just peachy keen, she was able to get connected to a doula. The baby was born 3 weeks early, but no NICU stay, and she's on an ongoing road to recovery. And so I'm going to end there, just kind of again highlighting the fact that intimate partner violence is real, mental health is real, and that there are resources and availability for things that we can do to kind of help our families. Thank you.
Wonderful job, Dr. Berry. I want to make sure that as we take some questions, we go ahead and comment, because Dr. Berry didn't get to see what's in the chat. One question about incest, I'd definitely like you to kind of address that. It actually came to a Tiffany Bell's talk, so Dr. Bell, you may want to address that as well. And I want to make sure I go on the record. I got the note from Dr. Barbara Stevens that we said in this section before that IPV has actually increased during the COVID-19 pandemic year. Not sure if that came out incorrectly in some comments made earlier, but clearly the numbers have actually gone up. But let's go take some questions, Dr. Berry. Let's make sure at some point one of us addresses the issue of incest. I'll open it up.
We want to go with something in the chat?
Yes.
Okay, let's go with, please emphasize again the importance of proper mental health care as integral components of prenatal care.
Yeah, I mean, 100%. It is something that well, for a while, people weren't talking about it. But I think more and more, I think our OB colleagues are starting to really understand that in order for the parent to actually have a healthy pregnancy, you have to really address and understand their mental health and their well-being. And so they are, not only are they screening about domestic violence, but they also do screen about depression. And then actually this past year, they actually also added anxiety to that cadre of what their screening is for. On top of that, as we've also alluded to, you can't just screen and not do anything about it. You have to connect them to resources. And so we're seeing this real big change in the country in terms of academic medicine, with the OB departments are really trying to also integrate with mental health or primary care, so that if somebody does get screened positive, we know what to do. We can connect them to resources. But on top of that, it's more than just thinking about, does this person have anxiety or depression? It's like, is this person safe? Are they stress-free? The other thing to think about that has been coming up a lot more because of what's been happening, well, not new to people of color, but new to other people, the George Floyd protests, has been thinking about race and racism and discrimination and how much that is an impact on their lives. And so I'm going to throw out a term called race-based traumatic stress, which is coined by Robert T. Cooper in 2007. That really understands the fact that racial discrimination has the same type of impact interpersonally and systemic as does PTSD. And so when you keep hearing on the TV or in the news about traumatic racial discrimination events, that can actually really kind of affect somebody's stress levels. And so that's something that I think the OB departments and American Academy of Psychiatry are also really starting to think about. How does racial discrimination also affect a person's well-being?
Can I just jump in before we get too far away from the question? Sometimes depression, anxiety, PTSD predate the pregnancy. And so one of the questions is, well, do I have to get off of my mental health medications because I'm going to have a baby? And so it's important to have those things, as Dr. Berry is saying, integrated so that folks know, no, you don't have to stop treating your depression and your anxiety because you're going to have a baby. But the interplay, as Dr. Berry was saying, between the mental health folks and the OB folks to make sure the medicines are safe and folks understand how to take their medicines. Again, just really important to emphasize the integrated part of Dr. Berry's question. Somebody put in the chat, I think Dr. Jordan, I don't know either, Dr. Jordan. One of these other smart people knows. What is a doula?
Apologies, yes. A doula is somebody who's like an ancillary service member to the birthing experience. And they should get qualified and get trained to do so, but it's somebody who's not like necessarily who didn't go to medical school, but who can really be an added level of support to the parent, to the mother who's undergoing labor, through advocating for her and making sure that she's being properly treated, being properly screened, being properly vetted, and really just another source of support. They also do great stuff by actually seeing families after the birth too. So thinking about postpartum, which is 1 year after being delivered. So really kind of helping that family really kind of take advantage of what it means to be a new parent or a parent of a second or third child in that moment. But it's really just an ancillary person who can kind of help provide more safety to that family. It's not a midwife, so they're not actually delivering the baby per se. It really is just a support person.
Oh, okay.
Right, and they really have, doulas have been recommended often, like Dr. Berry was saying, to African-American mothers to sort of advocate for them in these times where maybe their pain is not taken seriously, or if they have some concern about their blood pressure. And, you know, if you have a lower literacy, health literacy, you may not be able to say, look, my blood pressure's up, my head is hurting, I'm scared. And that doula will advocate for them and go back to the nurse, you know, as many times as needed so they can get the care they need. So it has been recommended as well that people do get a doula and have as much support as you can in these times.
Just as Sherrod mentioned with a question about this about incest, I want to give really the three of you a chance to address maybe all of you. But we've had this question before on the series we've done on IPB, and I think it'll be a very good day to address it, especially how it interplays with some of the more recent comments.
Okay, well, I can start the conversation. So incest occurs more frequently than we would probably like to think. I know when I was working in Richmond, Virginia, in the inpatient psychiatry unit for, you know, teens, children, adolescents, it was very common that someone would come in and at first they sort of give this vague story of, you know, being depressed or anxious or having an issue, and then you find out they've been sexually assaulted. They wouldn't tell you who. And then maybe, you know, a few days into it, you know, and depending on the parent, if they were in the home or not in the home, how involved they would be. But they often tried to block the child from sharing information. But eventually it would come out that there was a case of incest. And the main issue is these children often feel, you know, their primary support is sexually abusing them. So they have lots of psychological effects from that. But depression, anxiety, later on having drug use, having trust issues, problems with future relationships, suicidality, you know, it really does affect several areas of their life. And it is common. So I wanted to at least say that part. And I believe Dr. Berry may have something as well, or Dr. Bailey.
Well, I actually would like to make a comment on this. Incest is nothing new.
Mm-hmm.
And it is something that is in urban communities. It was well known in rural communities, and it has been well known in the Black community forever. And when I was growing up, my parents would never allow me to spend the night at someone's house. And I thought they were the cruelest people in the world, not letting me have time with my friends. And it wasn't until I became an adult and really a parent that I understood the meaning of the saying, you don't know what goes on behind closed doors. So, that was one of the things I was trying to bring out. We have stuff we don't like to talk about in our community. Incest is one of them.
I think to the points really both of Dr. Berry and I think Dr. Bale, I just want to comment on the idea that I think Berry was one that said it. If a third of kids are physically abused in a home where the one of the parents, i.e., very often the woman, the mother, is being physically abused, so your caretaker, can't protect themselves. So the message that they aren't going to be able to protect you, I think, is very clear. And then there's got to be a very short walk, metaphorically, from physical abuse of somebody who's smaller and weaker, your child, to sexual abuse. So I think that your point is well taken. I think the reality is this issue of sex with younger persons or incest is a lot more likely, one imagine, to occur in these kind of settings.
Mm-hmm. And I was just adding that I had that same rule growing up, and it does feel cruel, but we didn't get to go to sleepovers, and and you couldn't. Few people slept at our house. It was just anyway. You have to be careful because it happens, and it does. The person doesn't look like a monster, right? It might be your neighbor. You don't necessarily know what someone looks like who perpetrates incest. So,
And I'd like to comment also. Again, when we think about incest, we, by definition, are thinking about it within the context of family in the home. So when you go over to neighbors, provided that they're not blood related, that may be outside of the scope of incest. But I think one of the sort of classic things that we want to keep in mind is usually you'll have like a child who is helping or assisting, and it's usually a female child who is taking on the role of, say, a mother who is absent or maybe ill, and then they take on the role of a mother in the context of the family, and sometimes those lines get blurred, and typically you can see incest in those scenarios as well.
Any other comments from any of the panelists? If I go, I cut mine to 5 slides, and I'm glad I was mentioning Dr. Maxey. Our group goes longer and longer each week. We got good material. So hopefully this will go shorter, and I want to address a few points we end with some question and answer. Let's go to the sports culture slides. And as we do it, I mentioned the part about the incest. I mentioned the part about the Michelle, am I back on?
I can hear you now. You were gone for about.
Right, so I was just simply said the Richard
seconds.
Sherman case, and it just kind of points out, Richard Sherman or otherwise, how common these issues are, how much we know much more about them increasing now because of the ready access to what I call the worldwide media. Everybody in the world knows about Richard Sherman because football and sports in America is such a really big issue. And if somebody can see a video picture of it. So we had planned on discussing this male-dominant sports culture, and then that issue, I think, was in play. So I definitely want to get some feedback from all about that as we move on. But I'll begin my comments, and I want to show 4 slides. We take questions to everybody else. But so I play sports in college, and I play small college sports. Morehouse College is Division II, not large college where you feel like you're already getting paid $100,000 a year to play or what have you, which I think some of the issues are in play currently. But even in my setting, the culture of sports was dominant. Persons would engage in group behavior. They do some things in a sports setting or with a group that they, by definition, when you're on them separately, wouldn't do alone. There also, I think, was a group mentality, and it was group think in evidence. Not only would I think you see persons, a different personality would come out, and it'd be a bit more assertive, which is positive, aggressive, probably not, and very quickly become agitated or even hostile. One issue that I was always very cautious about or conscious about was the antagonism toward the LGBT community. I went to Morehouse College, probably the last standing all Black, all male college in the country. And I'm the first to say, I finished college in '86, 30 plus years ago. I mean, there was open hostility toward the LGBT community to a point of actual physical, direct hands-on violence in settings where persons could access individuals. And it was worse, I think, by and about those who played football and basketball. So these issues are real, they're very real in my life. And I've always had a hard time getting my hands around, why, what made that necessarily the case. So let's talk a little bit about it. Next slide. So we wrote this chapter in the book really to just address if there are any of a variety of reasons or rationales or encumbrances that actually lead to the issue of IPV. I think that all the panelists today, and this is our fourth month addressing this issue, I thank Dr. Max again for having us on, have regularly addressed it as more than just the standard or the typical or what we have always thought was a stereotype, always a man versus a woman, always in a setting where it's domiciled or in the home. There are many other variations in either the issues that come into play, as I think even my co-presenters today have addressed. So point out that really very little research on this issue regarding athletes. So that's one of the issues, is that this may be a different, unique subgroup, and we probably should do more work looking at them and trying to figure out what brings these issues about in this particular group. And are athletes the same in this country versus in other settings? Or are high school athletics very often where money is also in play different than other countries where mainly only are professional athletics? So different aspects or components of the athlete story that I think is very germane in a discussion about understanding IPV and ways to address it or manage it. I note that male athletes are more likely to become violent in relationships than male non-athletes. I think that piece is pretty well accepted. Also, this competitive, macho, violent nature of sports, and we think particularly football being the main bell ringer, but other sports as well, really cultivates aggression. I'm aware that even young women that play soccer, for example, notes would argue that they may be a bit more aggressive than other women who don't necessarily engage in that particular sport. There's something about sports that's a very pro-aggression-oriented setting that I think comes into play, I think, in this setting. All issues that may apply, that some of the same qualities that make you a better athlete make you a lot more likely to be aggressive outside the athletic arena. Next slide. What are some identities? Outward displays of masculinity, being tough, stoic, intimidating, really not talking. Often I said as an African male psychiatrist, I've been doing this 30 years now. People really miss the point when they think that blacks or black males or black male athletes don't talk or don't address what we do in mental health because in my practice, to me, they may not actually stop talking. This kind of points out that there has to be a button that's pushed that actually takes away the external veneer that implies that one can't be a regular person, that you don't have a humanistic side, and that you don't have all the components of life and emotionality in your psychology because you're a male or an athlete or what have you than others do. And I think that this false domain, so to speak, has adverse implications, and some of them may be to be more aggressive or violent in an IPV type relationship than one would actually have to be. We note some of the behaviors, throwing tantrums. We mentioned again the case just recently in Seattle, maybe considered dominant, very passionate, very engaged, good things in a sports setting, not so much I think in a regular relationship in regular everyday life. Women, displaying some of the same behavior, maybe viewed as being overly emotional or histrionic or butch or trying to be like a man. So in some settings, I think the dynamic is unfortunate because then I think we become very, we begin to finger point and become, I think, very partisan in our approach and how we look at women when they may engage in some of the same actions or some of the same behaviors. One does wonder, does that then lead to more unnecessary physical aggression in times by women who might be in a setting where they're trying to prove equality, quote unquote, I think in these kind of considerations, especially if they're in the more of the, if they try to be much more, not just dominant, but assertive in their engaged relationship. Next report that men socialize really to adhere, that there should be a patriarchal role, that they should be the head of the house, the leader, that their word is the last thing said. They would theoretically end conversation, end debate, and not really be open or congenial in their engagement with others, and allowing, I think, fair play, a sense of fair play in interpersonal relationships. All issues, again, associated with aggressive behavior verbally, which can lead to physical. I think Dr. Tiffany Bill pointed out that you generally don't start off being physically aggressive with someone, it may start off verbal. It may lead to odd touching or pinching and things of that nature. It may lead to pushing and grabbing before you actually get to actual physical assault. Next slide. We point out this, the role, I think, of sports. And I talk about fame and favor. And I don't mean this is only in regards to being on television, on CNN or ESPN, I guess it is, as a professional earning income. I grew up in Beaumont, Texas. And Beaumont, Texas, like many small towns, towns, period, definitely small towns all around the country. And Texas probably has a lot of reputation for such. If you were a high school football star, I mean, you were more popular than the mayor. There's just no doubt about it. And I was in high school, through 1982. I mean, to the point where when I would go to eat, restaurants would comp me on food. And it's the kind of thing that may happen, as you're an adult and you go to places and you see there's a professional athlete or what have you. But in a small town where there's no professional athletics or college sports or other persons who are in this, role of being the one that's identified as doing very, very well, high school sports can begin then to parlay some of these same concerns, and it may actually start somebody off in a negative direction or how to interact with others early in life, much more so than we would think would happen for anybody else who's 16 or 17 or 18 years old, who's good at whatever they do, play the violin or good in academics or good in some other kind of action. We note that athletes depend very often on this, or those who depend on it for their identity, their self-worth, and the like, may be overly masculinized because society is going to send it to them, and they're actually buy into it, that being overly masculinized and how they engage with others is what really matters to them and how they're viewed. And that may actually, I think, create more of a lighter fluid to a fire of hyper masculinity and very often aggression that can lead again to agitation and harmfulness to others. May turn to other actions though, drinking alcohol, using drugs, other things that very often may be associated with the same excessive behavior that can very frequently become out of control. We know that then very often somebody may feel humiliated or disrespected if then they're tied to losing that role. Injury very often can be a key item when that occurs, or some change when someone else or something else comes into play that becomes more important or gets more attention, I think, in that regard. And the last point, just because of fame, one should believe that the rules that everybody has to kind of play by, they play by. How often do we see persons, all too often young men, who think the rules don't apply to them? And our society all too often so engages. If law enforcement will arrest another young man for driving too fast and they throw the book at him or give him a great deal of legal complication, but because you're the star athlete, that doesn't happen to you. Of course, you may learn, I think, unfortunately, early in life, that you don't play by the same rules as long as you're very overtly hostile and aggressive, both on the football field, to use that example, or in your other aspects of your hyper-masculinized type life. Last slide. I think I anybody just said there could be some consequences. Conviction rate of male athletes who commit IPV lower than the general population. So again, I think even in our legal setting, there's a cultural domain that then doesn't want to punish many. But to Richard Sherman issue again, because there's a lot of discussion on the radio I was into this morning about whether the judge did a good thing or not in how that case was handled. And I hope for some comments and concerns here shortly, as compared to how other persons may be handled or addressed in a legal setting with a judge and a legal entity, especially if they have the video of the violent action that we saw. Conviction rates, I think, sorry for the typo, noting up to 31% of an accused male athletes being convicted. And I think it said about 3/4 of conviction rates of males in the general population. So clearly a lower conviction rate, even when arrested and charged for some of the same type behaviors in this setting. So precipitating male athlete violence is a problem. I think a substantive problem in our society. I think it's one sliver of the overall umbrella of IPV. We've tried to bring to you, I think, over the last 4 months, a variety of issues or concerns to think about in this setting. And I think this was definitely a key one that I wanted to address today. I think I'll end just with a conclusion.
Thank you so much, Dr.
Yeah, that's the
Bailey.
last slide. Good. So let's stop and take some questions, Dr. Maxey.
Yes, first of all, I'd like to appreciate all of the panel that you brought to the table. This has been very, very useful information. And I'd like to take advantage of the panel being here, in addition to the co-moderators, For a few days, I've been more than disturbed and agitated with certain things that are going on in terms of community violence, with a lot of shootings. But I think all of this may be part of a larger set of violence. I think there's inter-country violence when people don't protect other people by avoiding vaccines. We know right now that by people not getting vaccinated, we've created a situation where unvaccinated people constitute 99% of the people with new COVID and the deaths that are happening. It's happening in that community. As a psychiatrist, is there a war going on of violence against communities of color by people encouraging misinformation, by people willfully not wearing masks, by people willfully not getting vaccinated? Is that against communities of color that are more vulnerable to these things? Is this a form of domestic, cultural, country violence against our people?
Let me give each panelist a chance to respond. Jump right on in.
I guess I'll take this one first. Actually, I don't know if this one is particularly in the grand zeitgeist of everything, as specific to our community. I think I've looked at some stats and maps where there's a correlation to the surge of new COVID outbreaks that correlate to like people who voted for, and sorry to get political, Trump versus Biden. You typically see those who voted for Trump having this, being non-vaccinated and having this victim of this continued surge here with the second variants. Not to put everybody in a box in terms of political ideology, but certainly it seems like there's more working class Republican Trump voters who are certainly affected by this particular misinformation about the vaccine being harmful. And then you have the second camp of, I think, people who are always skeptical of, I guess, medical advancements and this vaccine being rolled out rather quickly, and harkens back to Tuskegee experiments and things of that nature, where there's just a complete sort of distrust of medical ethics in the community. But I think on large, in terms of like how the media is, and this is my opinion, propagating sort of anti-vaccination, I think it's skewed more to Trump supporting Republican states and territories.
Thank you.
Yeah, I mean, I'll jump in too. Alice, Barbara, did you say you wanted to say
No,
something?
go right ahead. Go right ahead.
You know, I think it's complicated, and it shouldn't be complicated, but it is. I have family members who are not vaccinated. And what that means in terms to me is, you know, the message about what the vaccination is and what it entails has not really fully been distilled enough for people to understand. And I think the way that the media has portrayed it, because a lot of people are getting their news from the media, has sometimes kind of highlighted some of this distrust too. And there is history behind it too about distrust, especially within the Black community. And we can't just ignore that. There is a lot of distrust within the Black community about it. But then how do you get the right information to the right people who can really feel like they are who are in control of their rights and what they want to be able to do? And that's a tricky part. And I think that's where medicine and science and unfortunately politics and media all get intertwined. And there's really not much there to kind of just say, this is what it is and this is what we should do. On top of that, you know, the CDC has kind of gone back and forth on many of their recommendations. And so when you have a public health entity that, one can't trust, and as supporting this, it becomes really hard for the individual population to also trust it too. And so what I've found is that when you meet somebody where they're at and understand what their worries are, what their concerns are, and talk to them on an individual basis, there is more movement in that way. And I'm just hopeful that we can still, that there is still, that people can still listen and be willing to listen and hear what else other people have to say.
Thank you. Dr. Barber, you had a question?
Well, I wanted to throw out a comment because I've been kind of thinking about this since I heard it. I heard a poll report this week that actually was of Republican Trump supporters. And of them, only 15% of them said if Trump told them to get vaccinated, that they would get vaccinated, which was very surprising to me. Maybe not to you all, but it was surprising to me.
Surprising to me too.
But the largest number of them said that they would take the advice of their personal physician.
Really?
Yes. And I've heard other conversations. There's been a lot of conversation, this week about vaccine hesitancy and getting the vaccine. And perhaps part of what is going on, I mean, it's an onion. It's got a bunch of layers. But I think, Dr. Berry, you were kind of hitting on one of the more dominant layers, which is the confusion, because nobody is taking a stand and saying, this is this, this is that, and so this means this. We have just nuanced everything from the get-go. So it may be now time to begin the conversation of, if you don't get your vaccination, then we are going to be in this situation for a much longer period of time. You are at a high risk of getting infected and having serious illness yourself, but even more importantly, you're impacting the health and well-being of many others.
Let me
selfish.
Let me emphasize what you say and take a prerogative of being one of the moderators. And I'm trying not to go to a conspiracy theory. And I did hear a statement once that just because I'm not paranoid doesn't mean everybody is not out to get me. I recall back when I was in medical school, I think I was in medical school, there was a riot at Attica Prison by the mostly Black prisoners. And they took hostage a whole bunch of white prison guards. And at the end of the day, the government decided that they would kill the guards to get to the Black prisoners and kill them. Put that in modern day terms. There is the refusal to pass the Voting Rights Act. There are 40 plus states that are enacting legislation to keep Black and brown people from voting. There have been instances of people fired in your state, Dr. Barber, for saying they wanted to go out and help people decide to get vaccinated. Everything is positioned to stop our voting rights, to stop our ability to get healthy. We're the ones that are most killed. And I do recall some years ago, the lady that I call my godmother, who was Frances Cress Welsing, wrote a paper called The Cress Theory of Color Confrontation. And in that paper, she mentioned the paranoia of whites that they could not produce color. Ladies and gentlemen, I submit that when you put a number of these things together, our communities are under attack, not just about the vaccine, but about life as we know it in general going forward. And I've also said that if you're in the foxhole fighting a battle, you can't really see what the general sees standing back on the hill. We have to be strategic and not just tactical. I believe every place we are under attack. And I think we need the input of our psychiatrists, such as the ladies and gentlemen on this call, to help us unravel this at a strategic level. I am extremely concerned, and I guarantee you I'm not paranoid, but I believe everybody's out to get me and the people I love.
Well, Ron, I'll jump in more than a few points. I'll take yours first. Three quick things. One, I clearly think that we would be remiss as professionals in any discipline. We are professionals in healthcare, but as African Americans, to give short shrift to the construct that there may be a larger problem. The reality is we've had several hundred years of these ongoing issues with the mistreatment of persons based on skin color. So the idea that there can be an ongoing assault, I think, on any number of institutions, including voting, because of skin color, I think does make some sense and does have merit. And it probably means that if there's a systematic approach to address it, there should be a similar one to combat it, i.e. having a Voting Rights Act, that there's an attempt to pass a bill, you pass it for 50 years, not indefinitely, after 50 years it kind of sunsets. I'd also say, though, that I want to address this issue. It's very important to me to address this today. I mentioned Richard Sherman a couple of times because I am just making sure that we get on the list for the chat or what have you. Versus, I think, in our group today, Dr. Maxine, this discussion about the woman, the African American woman, the wife of the athlete, if you guys heard about the story, who gets on the phone and calls the emergency group, 911, if you will. Her husband, if you saw the video, was outside, big football player, strong guy, banging on the door. Many might be threatened and frightened that they're going to be harmed. He's racing that door and he's yelling and screaming or intoxicated. And she gets on the phone and actually calls 911 or the law enforcement or the 911, the emergency person saying he's having trouble. We need help, but he has no gun. Don't come and shoot him. And I thought that was a huge issue for the ongoing discussion we've had in IPB on your show over the last several months, because this concept that some groups, especially African American women, have to have a different, if not even a dual perspective of what their concerns are, even if they've been a victim of IPV, which maybe she had, maybe she had not. She could was a victim of the verbal aspects of what IPV can mean if he was yelling or screaming or potentially involved in threatening action or behavior. And I think that actually speaks volumes to another consideration that we should have, I think, as Black health professionals, that when we're speaking with persons in our community, African women particularly, these dual roles that they have to have and have to engage in, it's essential for us to understand them, to know a bit about them, and to give recommendations and hopefully insightful treatment interventions, if you will, that take that into consideration. I thought that engagement of what she did that was on the news this last week, not the first time we've heard of it, was so striking. I want to make sure we kind of got that on the agenda for today.
Can I say something?
Where are you?
Wilbur?
Dr. Jordan is leaning into the camera.
Okay.
Yes, and Dr. James Hildreth, who's the president of Meharry, gave a talk last week at Drew, and he's been active in both HIV as well as coronavirus. It was an excellent presentation. It would be great if we could get a copy of it and show to the members. I mean, he pointed out that for the first time, all 4 components of the review committees, developers, everything has a Black person. One of the persons who developed this vaccine is Black, a former student of mine. I don't think we could say that about any other virus. So I think we have more reason to trust this one than we have trusted any. And I think it's kind of weird that people don't want to take it for whatever reason. This is nothing new. People have sometimes not taken other vaccines too. But we're hurting ourselves when we don't trust ourselves.
By not taking it, right.
See if we could get a copy of that tape. But it was very good. It was about 40 minutes, but it was very good for us to hear.
So let me jump in if I may for just a moment. First of all, Dr. Maxey, yes, you are paranoid, and yes, they are chasing you. So both of those, there's no mutual exclusivity to whether or not you're paranoid. Let me also
Can
say
he
this.
run? That's the question.
Oh no, he can run. He can run. He's a black man in Los Angeles. He can run.
You got me to run fast, huh?
Let me say this. There are very eloquent talks about how we should preserve our health. And they don't only relate to vaccine. They relate to managing diabetes, managing high blood pressure. There's a lot of good information that we get. And at the same time, there are very eloquent people speaking all sorts of weird stuff to us all the time. So there is a conspiracy in our community. Why do you think that intelligent African-American people ask many of us about, well, will I get magnetized if I take the vaccine? Those are real questions people ask. Will it turn me a different color? I heard they can track me if I take it. There are people who don't sound really crazy who are putting those things into our community. And so I think that there is some of that going on. We have to continue to encourage people like Dr. Jordan just did to know that everybody Black in a position of influence is not, and I'm gonna get in trouble, is not a Black Supreme Court justice who may as well not be Black.
Right.
I mean, not every, you can't just say Black people were involved. There were Black people involved in the slave trade. So I want to get back to the science of this. We have to be able to speak very clearly about what our positions are and why we hold those positions when we want to encourage people to change their behavior or act in a certain way. That's what public health is about. That public health is about encouraging people to do a certain thing. It's not only about giving folks information. So I'm with you, Dr. Maxey. I'm paranoid too, and I know they're lying to us. I know they're trying to get us, and that's what the Black Health Trust is all about. The caliber of people we've had on today that Dr. Bailey has brought on is just outstanding. And to know that there are these people at this level of academic accomplishment who are willing to come and tell us the truth makes a huge difference in our community.
Rod, I love your point, Ivan, because I think this is all about public health. I think that the issue of violence, and I'll comment that, we're all very happy now that the APA said it a decade ago, but the AMA said 4 years ago that violence in this regard is a public health concern. We won't get to it today, Dr. Max. I'm gonna bump it till next one because you gave me 5 and I got 1 more. But I've got 2 young people on today. They won't be able to present, but I just want to make sure I introduce them. Doctors Cabanez and Mion, and they're going to share some personal stories about IPV. So hopefully, you tee us up. If I get one next month, I'll give them both a chance to share those comments.
Well, thank you. I'd like to also recognize one of my former, I don't know if she was an intern, a student, or a resident, but Dr. Michelle Clark is on.
Thank you. Greetings, beloved. How's everybody doing?
Hello,
it's
Dr.
so
Clark.
good to see
Real good.
So many faces. It's wonderful to see you, Omawale. Let's congratulate Dr. Omawale Fowles, who has just completed her PhD and celebrated her achievement.
Fantastic, congratulations.
Leader in the African-American community, and particularly the African-American church community on health issues. And I'm so happy to see her as a member of the Black Health Trust.
Thanks very much, Dr.
Clark. This is a very serious subject, and the fact that we, lapsed into joking about it emphasizes that. What we're talking about is not paranoid. And I think it's really important that we understand that we are not paranoid, okay? We have 400 plus years history of evidence of the signs and symptoms of the viciousness of xenophobia and white supremacist racial abuse in this country and around the world. We are talking about some cultural paranoia. Dr. Arthur Whaley, a clinical psychologist and scholar, has written extensively about this. And I think it's time for another psychiatry presentation at the Black Health Trust. Thank you very much for the opportunity to speak. God bless.
Thank you
God bless
very
you
much,
too.
Dr. Clark. Dr. Bailey, our hats are off to you for bringing us another stellar program. And I thank Dr. Ivan Walks and Dr. Neighbor Stevens for hanging with us and making this program a success. And we're close to the top of the hour. If Dr. Bailey, Dr. Walks, or Dr. Neighbor has a brief 30-second final word, I'd like to recognize Dr. Ager and Pastor Pointer.
Well, in my last 30 seconds, I want to thank you again. I do think that we all are learning and growing as we move forward. I think you're doing a lot with this type show, especially with the co-moderators, helping us integrate issues regarding psychiatry and mental health in concerns regarding overall health. People use this term now, total health, to mean the chiasm between, total public health, primary care, and psychiatric care. And that's a huge issue for us in psychiatry, because historically, because of stigma, we've had a hard time really getting our message out. I thank again for the platform and the megaphone to do so. And on our next show next month, I think we'll find ways to integrate that piece a lot better. I also want to thank all of my co-presenters today. Good job, as well as our young people for the acknowledgement for the slides.
Yeah, stellar and superstars. Thank all of you.
Thank you.
Dr. Walker?
Outstanding.
One comment, Dr. Maxey, and it goes back again to something Dr. Jordan alluded to, how as he's talking with his patients, they don't connect with the piece about having a father. Our patients are so diverse and come from such diverse backgrounds. I think it's critical for us to be able to acknowledge that we won't automatically be able to know where they're coming from. We have to be open, much to the comment earlier about making sure your kids can talk to you and that there's an open microphone to them. The same thing to our patients. We have to be able to accept them from wherever they come and whatever background they bring to the interaction with us. So I'm just want to again thank Dr. Jordan for mentioning that. It's a critical piece of how we interact with folks.
Dr. Neighbor?
I'll only just say that we're still lagging behind as a people in vaccination rates. We need to take care of ourselves.
So our continued watchword is common sense. I'd like to thank our program producer, Simon Cooper, our virtual assistant, I started to call her Zucchini, Yakini Stevens, and also our hostess, Michelle Simmons, Pastor Pointer. Wait, I'm sorry, Brenda Ager, then Pastor Pointer.
Thank you very much to everyone today. It's been awesome and powerful. And I'll leave you with this. Walk with me, Lord. Walk with me. Walk with me, Lord. Walk with me. While I'm on this tedious journey, I want you, Lord, to walk with me. Hold my hand. I want you to hold my hand. Hold my hand. Hold my hand. While I'm on this tedious journey, I want you, Lord, to hold my hand.
Praise God. Colleagues, let me assure you how very valuable the Black Health Trust is. I began a pilot project talking with students and their parents about the vaccination. And I referred to the Black Health Trust right in the discussion, had one of the students pull it up on their phone and go directly to the episode where our brother, Dr. Jordan Despani, shared with us the myth busting around the vaccine. So that was done in a group setting because everybody has a smartphone and those phones tend to be smarter than we are, but we can make use of them. So the Black Health Trust matters. So let me close in prayer. Thank you, O Lord, for those of our brothers and sisters that you have sent to us today to share with us the wisdom and knowledge that you have given to them. Dr. Tiffany Bell, Dr. Uju Berry, Dr. Ron Bailey, and Dr. Mahayat Mahayat. We ask, oh God, that you would use us. So then I surrender to you, that I am no longer my own, but thine. Put me to what work thou wilt, rank me with whom thou wilt. Put me to doing, put me to suffering. Let me employed for thee, or laid aside for thee, exalted for thee, or brought low for thee. Let me be full, let me be empty. Let me have all things, let me have nothing at all. I freely and heartily yield all things to thy pleasure and disposal. And now, O glorious and blessed God, Father, Son, and Spirit, thou art mine, and I am thine. So be it. And the covenant which I have made this day on this earth, let it be ratified in heaven. In the name of your Son, Jesus, amen, amen, and amen. It's always a privilege, family. Thank you so much.
Amen, Reverend Pointer. Thank you so much for that blessing.
Bless you. And Dr. Files, congratulations.
Great job.
Take care, everybody.
Got a PhD.
Stay strong.
Okay.